I couldn't move the left side of my face at all. Yeah, I just told my husband, I said, I think I'm having a stroke.
31-year-old Leslie Pratt was having a stroke, but complicating things even further, Leslie was 8 months pregnant. Her case so rare, it's part of a case study. Good morning and welcome. It is Friday, January 6th. I'm Jessica Lovell. We are live inside the Dolph C. Simons Jr. Family Broadcast Studio. Pregnancy can be a stress test of sorts, straining the heart and blood vessels. Things like high blood pressure and preeclampsia and gestational diabetes can all increase the risk of stroke. We explain Leslie's risk factors and hear from her care team on how they pulled her and her baby through. So get your questions sent in to us on YouTube, Facebook, and the Medical News Network. You can find links to all of those right there on your screen. The Heart and Stroke Foundation of Canada found about 30 women out of every 100,000 experience a stroke during pregnancy. Leslie Pratt was one of those women, and she is with us today. She was treated here at the health system for a stroke at 36 weeks pregnant. We are also joined by some of her care team, nurse practitioner Craig Shipley and neurologist Dr. Laith Mali. How are you both doing today?
Doing great.
Good. Good to have you both. And Leslie, great to see you. I do want to start with you. Women might mistake stroke symptoms like headache or dizziness, tingling arms while pregnant. The body's doing all sorts of different things you might not be used to. Like we heard off the top of the program, you said you knew something wasn't right and you needed to call 911. When did you know to do that?
My 5-year-old came over to give me a kiss, and right away my lips wouldn't form correctly, and then I had to run into the kitchen and get something out of the oven, and my left leg gave out. So I yelled out to my husband for help. He thought, oh, you're having sciatica, you're very pregnant. And then I went to take a drink out of my straw, and everything just dribbled down my face. So I knew right away to go look in the mirror, do the smile test. My left side was paralyzed, so I called 911.
So you did everything right?
Yeah,
right?
exactly.
She did. And you kind of tested yourself. You kind of went through a series of different things that were happening, and you said, okay, third time, we're making the phone call. Kind of briefly walk us through, because I want to find out how you came here to our care team, but you went to a hospital close by, correct?
Right. I was taken to the nearest emergency department.
Go ahead.
So there, I think it took a team of specialists to kind of consult together, as there's not much information on, someone full-term pregnancy receiving TPA if needed. So once they made that decision, they explained the risks and benefits, and we decided to proceed.
And you have a medical background. Tell everyone what that is. So that probably went into you maybe knowing some of those signs, but tell everyone what you've done.
So I've been in healthcare for 14 years, working as a medical assistant and doing heart rhythm management with electrophysiology.
Leslie, when you were brought to that hospital, I remember when we talked, I sat down and did an interview many months ago, and you said how grateful you were that once the hospital that you were taking care knew that you needed a higher level of care, that you were taken here to the health system where you knew you could get that higher level of care. Tell us a little bit about that.
I mean, obviously, it was probably the scariest time of my life. I remember being in ICU at the other facility, and, I had a whole team come in and say, we're going to transfer you to the University of Kansas Medical Center. They have a much higher level of care. They have more in-depth specialists, and most importantly, they have a blood bank, because we don't know what this outcome will be.
So, Dr. Mali, how common are strokes in pregnancy? Is this something women who are pregnant should be, as if you don't have enough to worry about or think about? Is that something people should be thinking about?
Yeah. Unfortunately, there's no specific age that stroke does not happen at. In pregnancy, it's slightly more common than non-pregnant at the same age. So you're talking about 3 out of 10,000 pregnants get a stroke or have a potential to get a stroke, in comparison to 1 out of 10,000. So almost 3 times the risk during pregnancy.
So how do you manage that? I mean, what questions are you supposed to be asking your doctor? I know when I was pregnant, there's so much anxiety because you feel so different and weird, and you just want to make sure everything's going right. And a stroke is so serious. How can we manage that?
Right. So, I mean, stroke does not come as the first thing on your mind during pregnancy, especially being at a young age. It's very important, as Leslie did, have at least the basic knowledge about what a stroke looks like. Be fast. Look for symptoms of facial droop, arm weakness, leg weakness, problem with speech, problem with vision. It's very important to present to medical care right away. That allows us to have more options in treatment. Treatment consists of multiple things, including medication like clot busting medication that aim at dissolving the clot, and or a procedure to pull the clot out with a catheter. We call it endovascular thrombectomy.
So tell us about that TPA, the clot busting agent, and when it's used. And then Craig, jump in and tell us kind of what it was like when you first were introduced to Leslie.
Right. So a TPA is a medication that was approved in 1996. It's a clot busting medication. It targets the clot fairly specifically, and the hope it dissolved the clot. Again, multiple studies went to it. We can give this medication up to 4.5 hours from the onset or the beginning of symptoms. So we have time constraints. So that's why we depend on the patients to recognize the symptoms of stroke right away and to present to medical emergency as soon as possible.
Now, that's somebody just having a stroke. Even with someone who's pregnant, are there any risks or complications, any concerns?
Right. So the American Heart Association, their latest guidelines, they recommend to consider clot busting medication for pregnant based on the severity of stroke. So if we consider the severity of stroke of moderate or severe, then the benefit of the clot busting medication overcomes the potential risks. The potential risk we're talking about, bleeding as you're thinning your blood. In pregnancy, the situation would be uterine bleeding. Yeah.
So, Leslie, when I asked you, I said, when we talk to our patients, I always say, who are your physicians, who cared for you? And you gave me this long list of all these people who had had a hand in taking care of you and your baby. Craig, you were on that list, so tell us a little bit about how you were able to step in and use your expertise to help Leslie.
Sure. Well, first off, Leslie did a fantastic job recognizing those stroke symptoms because she was able to get care at the outside hospital in a very good, quick time so that she was eligible for the clot busting drug TPA. When she came to KU, she went, after you receive the clot busting drug, you spend 24 hours in critical care. So she spent 24 hours in our neurocritical care and for under close monitoring. As Dr. Molly said, you have an increased risk of bleeding. I got involved after that 24-hour period when she came out to the stroke service. So in those situations, when we get involved on the stroke service, once we've gotten through the acute stage, now we're looking at stroke prevention, preventing further strokes from happening. We're getting involved on the rehab side, and for Leslie in particular, she was pregnant, and so she didn't come directly to our service. She went to the OB service because there's it's essentially two patients.
That's exactly right. Well, you've just doubled your patient load.
Exactly. So there was a lot of coordination between the stroke service and the OB service and the critical care service, and to make sure that the workup we did was comprehensive, to find out why she had this stroke. Pregnancy it puts those patients at a little bit higher risk, but then we want to make sure that we do a comprehensive workup to make sure we don't miss any other risk factors such as a heart problem or blood clotting difficulties. So we do a very comprehensive workup, and there's a lot of coordination with the OB team on when the timing of these workups would be.
Well, that's what I'm trying to picture, all these people coming in again with their very narrow specified, their specialties to come in and make sure that they're kind of timing it all in this very short amount of time. We're talking about kind of this 24-hour period that you're doing all this acute care. Was there a concern about delaying the actual delivery of the baby? What was that? What question is asked when you're dealing with a stroke patient, but now you've got that other little patient?
Yeah.
Is it best to delay the delivery, the birth, or is it best to get the baby out? What were those conversations like?
So in Leslie's case, really we coordinated the workup that we had to do around the delivery. So we allowed the delivery to proceed as normal. And we coordinated with OB on when to do certain tests. Certain tests require radiation and different sort of contrasts, and so we spent a lot of time coordinating with them on when best to do those. And the decision was made to just allow the delivery to happen, and then we can continue with a lot of our imaging and after that delivery.
So Leslie, well, first I would just want to ask you how your babies are doing, because I know you have a 5-year-old already.
Yes.
So you were a young mom. You have a 5-year-old, so that keeps you busy. You're nearly 9 months pregnant at the time. You go through all of this. You're doing well though right now, correct? And your babies
yes.
as well?
They're
Tell
great.
us about that.
She is the sweetest little human on earth. If she would quit waking up every 3 hours through the night to eat, at this point, that would be great. But nope, big sister loves her. She's great. She really completes our family.
What do you remember most of that time? I mean, again, I think we have that fantasy, a vision of when we're going to, have our baby, and it's going to be this lovely moment, and the birds are chirping around us. And this was not the case. So tell us, what you were thinking this whole time. You've gone from this most joyous occasion to survival mode for you and your baby.
I mean, the original facility I was at, I was immediately transferred up to ICU, and I was told, we have main OR on standby. If for some reason that is taken, we also have labor and delivery OR on standby. We are uncertain of, what could happen. This is, not something we deal with often. And then when I was transferred here, I was told if things went bad, the risk of receiving general anesthesia immediately after an ischemic stroke not only increases the risk for another stroke, but it has a high morbidity rate. So that was terrifying. And then when I find out that my fibrinogen levels were still low after the TPA's half-life had worn off, that then creates more issues about if I were to need a nerve block or epidural for delivery, there's the risk of bleeding out into my spinal canal. So I feel like every time I came in, I kind of got, well, this could go wrong, but we're going to hope for the best. So it was scary, but everyone worked together and everything worked out great in the end.
Yeah, you were in good hands. Everybody knew what they were doing. Craig?
Yes.
Yeah. Leslie did terrific. It was just it was a great outcome. Mm-hmm. It appears Leslie has done fantastic in recovering, and a healthy baby. So yes, very good. It was anytime we have a stroke patient that is pregnant, because it is a very rare event, and so it gets everybody's attention very quickly.
I was going to say, you really get to put your skills to the test, right?
Yeah.
Absolutely. But it went very well.
So we have a QR code that we want to put on your screen, and you can click on it throughout the program, scan it, and it's going to take you to our stroke homepage where you can take a quiz to find out your risk factors, pregnant or not. So Craig, let's talk about those risk factors for all of us. And the right thing to do, again, is what Leslie did, which was, because they always say, time, seconds matter when it comes to that. So let's talk about the risk factors and then talk about what to do and the signs.
Sure. So your common risk factors, the most significant risk factor for stroke is high blood pressure. That's the number one risk factor that we look at, and one of the things that we really control once a patient comes to the hospital. High cholesterol is a risk factor. Diabetes is a risk factor. Obesity. Specific heart problems, atrial fibrillation specifically can be a risk factor. Problems with your heart beating efficiently in a heart failure situation. So those are the things we look at once a patient comes in. We look at all of the what risk factors does the patient have, and which risk factors could have contributed to stroke, so that we can target those risk factors and get them under control to reduce the possibility of the patient having another stroke.
Yeah, because you don't want to have to evaluate that once they're a patient. You want them to be knowing and thinking about these things before they're ever in one of your rooms, and you're seeing them here at the health system.
Right.
Leslie, you didn't have any family history. I mean, it's fair to say that the pregnancy was the cause. Are we able to say that is what or did she just happen to be?
So
Are you able to determine that?
Sure. So when she came in, we went through a very lengthy battery of tests looking at her heart. In every which way we could to make sure that the structures were okay. There wasn't any blood clots in her heart. Mm-hmm. We looked at her blood. We looked for all the different clotting disorders that can contribute to stroke. And fortunately, everything checked out okay. Mm-hmm. So in the end, it was believed that it probably was related to her pregnancy. Like I said, a pregnancy is a very dynamic event that happens to the physiology of a woman, and unfortunately, one of the side effects of that can make your blood a little bit more sticky. And so after we've ruled out everything, then we have to say that it was likely related to the pregnancy.
Quite a complicated case.
Yeah.
I know we're going to have community questions here in just a moment. Let's just take a quick break and check in with Dr. Dana Hawkinson, Medical Director of Infection Prevention Control. How are you today?
I'm good.
Good to see you. I know it's our first.
Seems like we're
our
back
first live
here.
show.
Yeah.
For Morning Medical Update of the year. So good to see ya. What you got?
Yeah, we were in with Dr. Stites on Wednesday, and over the previous couple weeks prior to this, we had saw an increase in our active cases, up above that 50 range from that mid-20s or so, low 30s. Right now, we have 45 active infections. Again, 73 total, but 45 active infections with 11 in the ICU and 5 on the ventilator. So the numbers are still, quite significant and impact patient care and capacity here at the health system.
Okay, so there's a new more contagious variant, now accounting for more than 40% of COVID cases. What's that about? What are your thoughts on that? What's that concern?
Yeah, I mean, again, I think we've heard this with every variant. It's more contagious than the other. It almost seems like just saying the word, the variant, is going to give you the disease, and that's not true. Really what people are focusing on here continues to be about the antibodies and the antibody evasion, and that isn't really, I wouldn't say too concerning. It's not too alarming. It is expected because we know the antibodies are so specific for every little spike or every little change in that epitope and protein. However, I think what we need to continue to tell the people is that really there's no indication that these are more severe variants, and I think that's good. Certainly we need to continue to do the basic science and the translational science to look at those things, not just the spike. But we know you continue to get very good protection from the vaccines because of those other that other side of our immune system, that T cell immunity, which when you're up to date with your booster, it continues to significantly reduce your risk of hospitalizations. But we also have the oral antiviral Paxlovid, but also the IV antiviral remdesivir if you're in the hospital as well. So we have mechanisms to help continue to reduce your risk of hospitalization and severe outcomes, and I think that's really what we should focus on. I don't think it's going to be surprising because we've been going through this now for 2.5 years, just seeing other variants arise and maybe evading antibody neutralization more than others. But the main point is we still have that immunity to protect us against severe disease and hospitalization. That's what's important. And if you get tested early and you meet that criteria or at high risk, you have that ability to get Paxlovid in general. So I think those are all things that we need to continue to understand, and hopefully that will continue to help us move forward. Overall, the cases in the United States are much, much lower than they were, last winter with the Delta or the original Omicron surge. They are still quite high. Deaths are still fairly high, but nowhere near those levels that we were seeing previously, and so that is all good news as well.
It is. Doc Hawk, thank you so much. Let's see if we have any reporters on the line today. Let's get to our community. Rita wants to know, Leslie, how long you were in the hospital before you and your baby got to go home finally?
So luckily we were discharged 2 days later. My blood pressure was stabilized, the baby was doing great, so they said as long as I promised to check my blood pressure continuously at home and report any abnormalities, I was safe to go home.
And Amelia's curious if there's any risk for Leslie for future pregnancies, or if somebody has this happen to them, are they going to be high risk? Is this going to be something you're going to be checking out for other pregnancies and women?
Right. So it depends on risk factors, as Craig mentioned. The fact during pregnancy you have specific risk factors related to pregnancy itself, like preeclampsia or eclampsia, or fetus clotting, and the slightly higher tendency for forming clots. Some of these are just specific to pregnancy, so the recurrence rate of stroke, if that was the specific reason, is usually fairly low. If you have other competing risk factors, like a heart disease or atrial fibrillation, other compounding risk factors, then the risk becomes higher. In general speaking, risk of ischemic stroke in recurrent pregnancy is considered fairly low. It's usually around 1% of patients.
Joellen is curious, what's the upper age limit for receiving that stroke drug if you're not pregnant?
Yeah, there's no upper age limit. We give it to
You're getting
pretty much like high 90s years old patients. Yeah.
Okay.
Yeah.
Yan Liang, are there any connections between pregnant women with stroke and DIC?
Yeah.
So explain what that is, but
Right.
what can be done, if anything, to prevent DIC from happening? So tell us, educate us on that first.
Yeah, so DIC is a condition where there's a abnormal clotting that happens. There's usually a trigger for that. It leads to drop in platelet numbers. On the same side, there is a lot of aggregation platelets. So platelets are forming clots somewhere else. So you're forming clots and have risk of bleeding at the same time. It's kind of like, interesting situation. There's usually a trigger. A lot of times it's infection related to pregnancy. Sometimes there's like a uterine bleed or retrouterine bleed behind the placenta that triggers this type of conditions. This is considered a medical emergency. So most of the times we or the OP team, obstetrician, they try to deliver the baby to be able to manage at least one patient at a time. And it's risky for the baby at the same time.
Craig, you mentioned this earlier. Sadie wants to know if TPA is something that has to be administered within a certain time frame. You mentioned the time frame that Leslie, great news that she got the care that she got because she got there in time to be able to receive certain medications. Explain that.
Yeah, so TPA are clot busting drugs. We use tenecteplase now here at our facility. And typically it's 4.5 hours from the onset of symptoms. And we have some protocols in place where we can get a rapid MRI. And in specific circumstances, we can extend that window. But typically, the vast majority of our patients, it's at that 4.5 hour window from the onset of symptoms. That's why it's so important to recognize those symptoms quickly and to act quickly, just like Leslie did.
Be fast, right?
Yeah.
That's exactly right.
Okay, so remember that. And average age of a stroke. Average age,
Well,
I mean, you said it could happen to anybody, but...
Yeah, it could happen to anybody. For pregnants, usually the average age, I would say, not for pregnants, in general, it's about like 69 years old, 60 point something.
But don't let age fool you.
Exactly.
Know
Yeah,
your risk factors,
yep,
right?
Yep.
Jamie wants to know, Leslie, if you struggled with anxiety after the stroke, once you came home, was it kind of smooth sailing, or was there something kind of in the back of your head thinking you got to really keep your health front and center?
Yeah, I mean, I'm already a heart patient. I've had multiple heart surgeries, but this was probably the scariest thing ever. So when I went home, my phone was by me at all times, especially while my husband was at work and I was home alone with the kids. I was obviously just, still a little anxious, so I always made sure my phone was close by. If I had any abnormal symptoms, I had 911 on speed dial.
Yeah, fair, good advice. And speaking of that, Becca wants to know kind of what you've learned from this entire experience. You've had a health history. It sounds like you're on it, but is there any words of advice as far as trusting your gut?
Yes, of course, trust your gut. If you have that gut feeling that something is not right, don't question yourself like I did for a moment thinking, oh, maybe it's just Bell's palsy or something. Don't question yourself. If you're having any symptoms that concern you and you just don't feel right, get help. No one's going to judge you if you go to an emergency department and it's not something major. You would always rather be safe than sorry.
Amen to that. Okay, we're going to get to final thoughts real quick. That QR code takes you to the stroke homepage where you can take a quiz to find out your risk factors, pregnant or not. Take that quiz, find out where you stand. Let's get to some final thoughts. And Craig, I'll start with you. What do you want us to know? Kind of what's the big takeaway as we head into the weekend?
Well, I think as far as when we talk about pregnancy and stroke, we just want people to know it's very rare. But I think the most important thing, the most important takeaway is make sure you get your appropriate prenatal care. You're following up with your OB-GYN doctor, and to understand the symptoms of stroke. Facial droop on one side, weakness on one side of the body, difficulty with word finding, confusion, a sudden loss of vision in one eye, or difficulty with walking.
Yeah, recognize it in yourself and also recognize it in those you love, your colleagues.
Precisely.
Anyone around you. Dr. Molly, final thoughts?
Yeah, so To add to what Craig said, present to the emergency department as soon as possible. It's important to present to healthcare. Most hospitals currently they're able to administer thrombolytic medications, TPA or TNK, but we always here at the University of Kansas are available just one phone call away. The hospitals, no matter how small they are, they can get a stroke expert on the line within 1 minute. So they can get our expertise in terms of thrombolytics. If there's a more complicated case, just like Leslie's case, they always can request a transfer to a higher level of care. So we're here at Comprehensive Stroke Center. We're highly designated by the AHA. So we deal with very complicated cases on a daily basis.
Comforting to know. Thank you so much. Leslie, any other final thoughts from you today? Just what do you want us to know?
No, I'm just very grateful for all of my care here from every specialist, every nurse, everyone that helped. And I'm very excited for this case study to come out and hopefully give other physicians a little more insight on what labs to check, et cetera, to help, ensure the safest delivery as possible for the mother and baby.
Thank you, as always, to another great patient willing to come forward and share their story. So, Leslie, thank you so much. Enjoy those sweet babies of yours. Dr. Hawkinson, final thoughts?
Yeah, it's good to be back, and hopefully we can continue to educate the community about all of these health topics. We'll also continue to educate about, obviously, COVID, influenza, all those other illnesses that we've seen, both here locally, but also those other things that could impact our other communities in the United States as well, and of course around the world. And so everybody just stay tuned. Hopefully it will be quiet in 2023, but I think if the last couple of years are any indication, it probably will not be. So there'll be a lot more information to come.
But you said it. It is good to be back, isn't it?
Yeah.
I thought I was going to be a little rusty today, but I think I made it after a couple of weeks off, right?
That's right.
All right, we made it through, and it's Friday, even better. So thank you so much for being with us today. Catch our updates anytime by logging back onto Facebook, YouTube, and Twitter. Go out, make it a great weekend, and we'll see you back here Monday at 8 a.m.
Coming up Monday on the Morning Medical Update. You do your part and donate blood, but what happens next? How is it distributed and processed once it arrives at area hospitals? I'm Jessica Lovell. Coming up on the next Morning Medical Update, we take you behind the scenes to show you how blood products are processed to make sure they're ready when patients need it most. See you Monday at 8.
Subscribe to our Morning Medical Update and Open Mics with Dr. Stites podcast. Now everywhere podcasts are available.